for instance, if I get a phone call, they're telling me, hey, Dr. Matar, this guy has been stabbed and where he's losing his vitals. Well, I need to be there faster. And so I'm almost risking myself as well, driving at night in a storm potentially, going down the roads when it's pitch dark to get there in time. You get to the hospital, you got to run through the doors, and you don't know what you're going to see. Your heart is going, at least it does for me every single time, and I wonder if it does the same for all my colleagues. But every single time the heart's just beating, and you get there, you put on your personal protective gear. That's typical of trauma, regardless of whether COVID or not. We've always been doing that. And then you get in, and you get report on what they have received or what the patient's suffering from. And now you got to slow down. You really got to slow down your heart. You got to be able to focus again. And the way I've learned to do it is I'll actually put my hands on the patient's feet and I'll feel for their pulse. And that kind of, I feel it grounds me and reminds me, okay, slow down and let's focus on the patient. And you go back to your training and your algorithmic approach to the trauma patient. You're asleep, and then within 25 minutes, I had my hand on his heart in the emergency department because he had lost his vital signs. That's not normal. That's not normal even if you were awake doing that. And to go do that and then perform a maneuver that's quite extreme, and then the patient survive and leave the hospital, you know, you feel like you've done something good, but there's nothing normal about that.